must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
All right, moving on then. I want to talk about actual tendon management now. Mm-hmm. And so I know you've broken it down into several stages in a 4-stage process when it comes to typical return to play management for tendinopathy. If I start at stage 1, this is kind of where we hit a little bit more controversy again when it comes to the pain management, the isometric contractions, right? Mm-hmm. Now, obviously, when Ebony Rio's paper came out in 2015, that got a lot of press, and that made the rounds along social media, and people kind of took that and ran with it when it came to the role isometrics play. Yep. And then people did the exact same thing because we apparently never learned when Seth O'Neill's paper came out this year, and it failed to completely replicate those same responses. So if you could kind of walk me through where isometrics stand now in their role in tendon management.
Sure. So it's interesting that those two papers are put at an equal level. Ebony's was a randomized controlled trial looking at the mechanisms underpinning isometrics. Seth's was a case series. So I don't think you can necessarily say that one showed a good result and one didn't show, because I don't think they're equal in terms of the research capacity. There's another word for that. I don't know what it is. So the bottom line is that when we see a lot of people who've tried isometrics and not been successful, and the thing is that people will read isometrics are good, and then they'll apply whatever they feel like might be appropriate to the person. The answer is that when Ebony got such good results in her study, it was heavy load. It was 70% MVC, and it was for 45 seconds. It was a 2-minute rest, and there was 5 repetitions. We see people who've been given, 10 lots of 5-second holds. Just go and push against the wall with your foot so that will load your patellar tendon isometrically. Just rubbish application of isometrics. So clinically, it's not done well enough. It's sort of like the Alfredson program where he showed 3 lots of 15 of bent and straight knee twice a day was effective. Then everybody made up their own version of that. And then they said, oh, well, it doesn't work. And that is pretty much the same with isometrics. With Seth's study, that was done in seated and in a plantar flex position. And we know that you can't get enough load through the Achilles tendon in that position. You have to be standing, and you have to be in more dorsiflexion to really be able to load. So it's quite possible that was just an underloaded isometric protocol. What we do know is clinically, we use this diagnostically, and we make sure we do a really good isometric protocol. If we get to the end of a subjective and an objective examination and we're still not sure, is this tendon pain or not? And you can do that because sometimes it's a complex presentation. If they respond to isometrics, we're much more comfortable that they're a tendon pain. If they don't, then we're much more comfortable that they're not tendon pain. That's how sure we are that it's effective in immediately reducing tendon pain. But it's got to be done correctly. You can't do very low load, very short holds and not do your repetitions properly and get an outcome. And so that's a little bit of a rant, but if it's done correctly, isometrics offer us a really good short-term option. And this is the other thing that drives me a bit nuts about this. Oh, we have to be careful about isometrics. The answer is what have we got to lose by trying them, for goodness sake? All you're doing is asking people to sustain a muscle contraction for a period of time. You don't have to have caution. If it works and you do it well, great. If it doesn't work, you haven't lost anything. So I think they work in tendon pain. Some people don't. I'm really happy with that. I don't necessarily think they're always done very well, but I don't think we have to be cautious. We can actually use them, and, you know, if we get a response, great, and if we don't, then so be it.
Okay, awesome. So to sum up, it looks like we need to be more diligent about the application of the isometrics, correct?
Yes.
And
yes.
So I'll give a couple of examples here. So in terms of the leg extension, if we're working with patellar tendinopathy, what parameters should clinicians listening use to make sure they're getting the benefit from this intervention?
Okay. So the leg extension is by far the best for the patellar tendon, and because patellar tendon occurs in young jumping men, if you're diagnosing it outside that group, you're actually wrong with your diagnosis. That's the first thing. So they can be, they can get into the gym really easily. You know, measuring 70% or measuring maximum isometric voluntary contraction is really hard. So the clinical perspective of how we do it, and we don't measure MIVC, we look for a weight that they can hold single leg very well controlled for 45 seconds. And that's what we consider to be around 70% MIVC. So if they get to the end of their contraction and they're saying, well, I could probably last another 15 seconds here, it's not heavy enough. If they can't sustain it for 45 seconds, it's too heavy.
Okay.
So
you're using some sort of subjective feedback to monitor the load there. Okay.
Yeah. And, you know, we have the ability to actually trial our isometrics in our first consultation. So we have access to a gym, which makes it really easy. I think sending people away with some esoteric isometric exercise is really hard because people don't understand what they're trying to do. I think you actually have to show them what to do. Or if you can't show them what to do, give them something and then monitor them for the first week or so until you're sure they're actually getting a decent load on that tendon. As I say, for the patellar tendon, it's really easy. If it's patellofemoral pain, and we see a lot of patellofemoral pain masquerading as a tendon pain, they won't get through the first repetition. First repetition will make them a lot worse. And so you can be relatively sure very quickly that you're not dealing with a tendon problem, and then you alter your treatment and your rehabilitation after that immediately. So I think that's how we do it clinically. Obviously in the Achilles it's much harder because you can have your young sprinting athlete who might need external loads. You can have your, you know, middle-aged to elderly person who can't sustain their body weight on a single leg. That's too much load. So you have to do double leg holds. Or some people, even people really disabled, we start on seated calf raises because we can't put body weight loads on them. So the spectrum that we see in that is much broader, anything from 5 kilos seated right up to single legs standing with, you know, 20 or 30 kilos. So the Achilles is much harder, whereas the patellar tendon is quite simple. Leg extension, as much weight as you can hold, 45 seconds, that's it.
Okay. Now, for clinicians that may not have the luxury of working in a gym setting or having a leg extension available to them, or say their patients don't have access to a gym, what would be a reliable substitute for that?
Yeah, it's really interesting. You know, we can work around most other tendons. The patellar tendon we really struggle to work around with because it's a young jumping man's condition. If you are a young jumping man, we have to get high loads on this. We can't mess about with wall squats or elastic resistance is what we see all the time. Oh, yes, I'm holding against, you know, blue TheraBand. Oh, my goodness, it's really hard. It's just not even close to enough load. However, there is an alternative, the Spanish squat, or I don't know, I get into trouble by calling it the Spanish squat. Angel Bassis did a fantastic case series of athletes, so jumping athletes. This was the elite Spanish triple long high jump athletes, and he does a fantastic protocol, and he's written that up in the IAAF journal, so it's worth looking at that. So that's a belt around both calves where you sit back down with the belt in front of you and you sort of sit back. That's a fantastic, good option for people who don't have access to a leg extension machine. So it'd be worth just looking up his paper and seeing how he does it.
Great. Yeah, that'll definitely be a good resource for people who don't have that option. So that kind of leads into phase 2, and we're emphasizing the importance of heavy when it comes to these tendon management strategies. And so I kind of want to dive into that topic a little bit for why the intensity or the absolute load you're putting on that tendon seems to matter.
Okay, so the first thing is that that's what changes mechanical stiffness. So you have to have a heavy load to get some mechanical changes in your tendon. So that would be the first thing. The second thing is that when we see people with a tendon pathology, tendon pain, they usually have massive amounts of muscle wasting. And so we need the heavy loads to really restore muscle bulk and muscle strength. These people really seem to lose muscle strength and endurance and bulk quicker than any other condition I know. So we really have to restore the muscle because it's the muscle that controls the energy storage and release loads on the tendon. So if the muscle isn't strong and doesn't have good endurance, then we tend to get aberrant loads on the tendon when we return to our faster sort of more energy storage and release loads. So I think from a tendon perspective, absolutely. Mechanical strength. From a muscle perspective, absolutely. Muscle strength seems to be the thing that gives us our best protection against tendon pain.
Interesting. So I kind of want to caveat for that for a second, because when it comes to muscle tendon dynamics, it can be a little bit confusing for people, and they don't always understand the clear interplay there about how the tendon acts. It's out of phase with the muscle contraction, right? So the muscle will contract almost isometrically at first, and the tendon will elongate, and then it changes the rate of release of energy to the muscle, correct?
In energy storage and release loads, yes, that's
okay.
What happen, but not in slow heavy resistance training.
Okay.
So slow heavy resistance training is almost no tendon load, and this is where we see a lot of people go wrong clinically, that they say you have a tendon problem, you shouldn't do weights because that's loading the tendon. The answer is the only thing that loads a tendon is faster work. And so if you do slow heavy loads, the tendon is as happy as it can possibly be. It doesn't cause it pain. If it does cause it pain, you have to think about your diagnosis. It changes the mechanical strength, as we've talked about. So there's nothing about heavy, slow resistance training that's negative for a tendon. It's all absolutely positive. The OPES stuff is interesting, and it comes back to our isometrics. He showed that you needed 5 repetitions to condition the tendon. So you sort of get some tendon, I think it was changes in length, but you get some tendon changes for 5 contractions, and then you have a stable tendon. So, that might explain why our 5 contractions for our isometrics are more effective. But once you have done one set of your heavy, slow resistance, you've got a pretty stable tendon. It's not going to be affected by it, and it's a very positive thing for the muscle and for the tendon.
Okay, so that kind of leads me down 2 different paths. So if during heavy, slow resistance training, it's very little load on the tendon, why do we see mechanical changes in the tendon then?
This comes back to that the discussion we had. Nobody knows where the mechanical changes occur in the tendon. Mm-hmm. Logic would tell us that it's the interfascicular matrix stiffening, but Hazel doesn't know that at all. She says, I haven't got a clue. For me, if we saw changes in mechanical strength with plyometric, faster energy storage and release loads, I would say, yes, that's definitely, it has to be the interfascicular matrix that's stiffening. But those loads don't change mechanical stiffness. It's slow, heavy loading that changes it, which then makes me think that it must be in the fascicle, that something about the collagen within the fascicle or the whole fascicle itself that changes mechanically. But I don't think we know that.
Okay. And then in cases where the tendon may not be pathological in isolation, so say there may be some peritendon involvement, maybe there's some fat pad issues going on, would that lead to some sensitivity with these type of loads that may create some intolerance?
They're 2 completely different pathological and clinical presentations. So a peritendon is because you do too much movement. So you almost never get a peritendon problem by too much energy storage loads. You get a peritendon problem by having very low loads but doing big movements repetitively. So for that, the treatment for that's not going to be heavy, slow resistance. It's about taking away the loads that create it, which are the friction loads, stopping moving the tendon through lots of range of motion. Isometrics help really a lot because you can keep the load on the tendon. So it's a completely different perspective of how you would address that. Fat pad, oh man, that is a big rabbit hole. We haven't got a clue. We've got a clue about the fat pad. We know it changes because it becomes hyperechogenic when you have a tendon pathology. We know that it produces cytokines. We know it's highly vascularized. We know that it's highly innervated. We haven't got a clue what role it plays in tendon pathology and tendon pain. I don't know the answer to your question. Having said that, clinically we don't address the fat pad at all and we get good outcomes. So that makes me think it's not as involved. The second thing that makes me think it's not as involved is if the fat pad drove a lot of pain, everybody who had an arthroscope in their knee, where you put these massive portals through the fat pad, would have huge pain problems afterwards. We never see portal pain, or very rarely see portal pain or fat pad pain after you've stuck these massive, holes in it. That doesn't make sense to me either. So I think we don't know anything about fat pad. I don't think it's a big player, but I don't have the evidence for that.
Okay. So I guess it goes back to the importance of getting the diagnosis right in your mind?
Yes.
Okay.
It's probably the thing in our desperate and dateless clinic that we see. We always say for a tendon clinic, we don't see a lot of tendons. The answer is people are diagnosing tendon pain on palpation soreness, which gives us nothing, and imaging change, which gives us nothing. Neither of those are diagnostic of tendinopathy. And that's what people do all the time. Hurts to poke, oh, your imaging's abnormal, you've got a tendon pathology, tendon pain. Therefore, this is what we're going to do. And so you can have both of those things and not have tendon as the source of your pain. And I would think close to 50% of people we're sent with tendinopathy don't have it. Something else is the source of their pain.
Okay, so for those listening, so they can be sure to stay out of that group that misdiagnosed patients, what are your hallmark signs that you have to see to make sure this is a tendon pathology?
It's really simple. It's localized pain with loading. And when we talk about localized, we're talking 1 or 2 fingers. So people must point with 1 finger to the area of their pain, occasionally 2 fingers. If the pain is spreading, it's not going to be tendon pain. The second thing is it's got to be load-related pain. So if you don't load it, it doesn't hurt. If you do load it, it does hurt. And it must hurt more as you load it more. So in the Achilles, it's really simple. Double leg heel raise should hurt not at all or a little bit. Single leg heel raise will hurt a bit more. A jump will hurt more. And a hop will hurt the most. So if you don't see that increasing pain with an increasing load on the tendon, then you probably don't have tendon pain. You could have peritendon pain because that's one of the classic hallmark signs of peritendon pain, but it's not going to be tendon pain. You have to be so careful. So they would be our 2 hallmark signs. Clinical signs, the second thing is, morning stiffness for the Achilles tendon is an absolute. If you don't have morning stiffness, look somewhere else for your source of pain. And other tendons have hallmark signs: night pain for glute tendons, sit pain for hamstring, car pain for patellar tendon. They're a little less absolute than the Achilles tendon. But for me, localized pain that doesn't shift, that increases as you increase the load on the tendon.
Awesome. So I kind of want to go into what may be the role of different tendon types and the efficacy of heavy, slow resistance training for those. So say we throw out a common thing I'll see in my clinic is rotator cuff tendinopathy, people coming in with that diagnosis. And then there have been some studies looking at differences between high load versus low load training and not really finding much there. Can we speak on that and why we may have discrepancy between that tendon versus the traditional energy storage Achilles or patellar tendon?
Yeah. So first thing, rotator cuff is not my area. There's people who are very much more skilled and knowledgeable in that area. I think 2 or 3 reasons that make sense to me why it might be different is, one, I'm not sure it's an energy storage and release tendon. It could be a positional tendon. Now, positional tendons don't give us tendon problems. So if you think about the tibant, is a particular one. I'm just trying to think of some others. Our distal and hamstring tendons don't tend to give us problems. So if they're not an energy storage and release tendon, we don't tend to get into trouble with them. So I wonder if the rotator cuff is more a positional tendon, particularly supraspinatus. Now, that doesn't make sense to me either, because our posterior cuff must be a massive energy restore and release, because it has no agonists. So it must be the one that stores and releases energy on internal rotation of the shoulder. So I don't understand why we don't see more pathology in the posterior cuff if it's an energy storage tendon. The anterior cuff should be an energy storage tendon, but we have lots of fantastic agonists there. So we have the pecs and the lats and all the things that will take the load off the anterior cuff. The supraspinatus, I don't know. I think it's probably more positional. So I think that's probably all I should say, because this is really not my area of research. But I think it's very different from the lower limb tendons.
Okay. And I'll leave it at that. I won't make you speculate too much on there.
No, I'd rather not.
That's fine. Do you have anybody that you recommend to read who's working?
Jeremy Lewis.
Gotcha.
He's fabulous. He's got some really, really good research. He's really making some fantastic inroads into understanding of subacromial pain syndrome. I think that's what it's called these days. We're not even sure the tendon's the source of pain there. So, he would be the person I would be listening to.
Great. And then moving on from there, the next couple phases of rehab, some other important considerations. I know you've written a good bit about the role of compression when it comes to tendinopathy management. Do you want to kind of expand on that a little bit?
Yep. So we talked about the Achilles being the only tendon that fails in the mid tendon. Everything fails at the bone tendon junction. And if you read Michael Benjamin's work on the emphasis organ, what he shows is that the tendon will always come over a bony prominence before it inserts. The bony prominence is there to protect the tendon, to give it a mechanical advantage. That is where we fail. We don't fail at the bone tendon junction. We fail proximal to it at the point of compression. And so removing compressive loads is such an important part of managing tendons. And so in the early phases, certainly in the isometric and the heavy slow resistance phase, we stay away from a compressed point for the tendon. That usually means we need to stay in mid to inner range with our exercises rather than our outer range, which is where we tend to see compression. Obviously, as we get back towards the energy storage and release and back to the sport specific, which is stage 4, we have to have compression. We have to be tolerant to compression. So we tend to introduce it in the stage 3, stage 4 parts of the program, because we have to be able to take those loads if we're going to be successful at returning to our activity.
Okay. And then how is your monitoring system in place for kind of measuring when to introduce this and at what rate?
So tendons are wonderful things to treat because they're very clear when they're happy and they're very clear when they're not happy. So a tendon will tell you one day after you've loaded it if it's unhappy. So we always monitor our tendons on a daily basis with either a loading test or a subjective test. You know, how stiff are you this morning? If your morning stiffness or your pain on hop, for an example, is increased the day after you've changed your activity, you've done too much. So the simple thing with tendons is we very incrementally change loads, and we do it so that the tendon isn't exposed to a sudden change in load. The tendon thinks that it's getting the same load, but in fact you actually snuck it up a little bit. And it will just slowly adapt to that. If you go up too quickly, it will clearly tell you it'll be worse the day after you load. You then know that whatever you did the day before was too much. You did too much compression. You did too much energy storage loads. So you just alter it. And that's why we only ever change one thing at a time. If we change 3 things and someone gets sore, we've got no idea what's hurt it. So we just say, okay, well, whatever we did was wrong. Let's try that in a different way. Let's reduce the compression or reduce the energy storage loads. hopefully the person will be less sore or not get a flare the next day, and then we can just continue to go on. So tendons are really simple. Just monitor them. They're not obtuse in any way. They're very clear. I didn't like what you did yesterday. End of story. Don't do it again.
Well, great, clear. I just wanted to make sure we had something on there for people to know. It's usually pretty clear, and just having some sort of monitoring feedback system for the patients so if you're doing an appropriate amount or not, right?
And education is so important. If you teach people to monitor their tendons, and I'm not talking about writing down exactly how much pain they have each day and, doing testing. If they are a bit sore one day, and you educate them properly, they very quickly learn that what things they have to be careful of. They know what they did the day before wasn't right, therefore they will adjust it. The problem that people get into if they're not educated is they'll come in and say, I was really sore this morning and I haven't done anything wrong. I've done nothing wrong today. And they don't get the fact that it's a 24-hour response. So as soon as you teach them, well, what did you do yesterday? Oh, well, I picked up the kids and ran 5 miles and, did a million other things. As soon as they get that correlation, they get very clever at monitoring themselves, and you can sort of step away from that, and especially in the later stages of rehab. So education is really important in people understanding this.
Awesome. And just so I get this on record and I get your opinion on this, so you'll get a lot of clinicians advocating for using interventions like, say, instrument-assisted soft tissue, like some of those, the Graston techniques, some of the scraping, as a form of compression to build up tolerance or whatever explanation. What is your view on their use within tendinopathy management?
Whatever explanation is perfect. You ask them to tell me what they're doing and how they're having a positive effect on the tendon. That they won't be able to. They'll say, I'm stimulating collagen production. Well, that doesn't make sense because we've got plenty of collagen. We've got more collagen, we know what to do with. It's just the wrong site's not in the matrix. Oh, I'm affecting the vessels. Well, nothing you do affects the vessels. I'm affecting the pathology. Nothing you do affects the pathology. And in fact, you can make people worse. If they're acutely sore and you go poking about in that tendon with dry needling or any sort of thing, you can actually make them worse. So I would first challenge them on what they're doing. And second, sometimes I think you get a short-term benefit. We know that the nerves are peripheral in tendons. They're in the peritendon and in the bone-tendon junction, muscle-tendon junction. So people will walk away feeling good for a couple of hours. But tell me what that changes in the long term. So one of the things I say to my patients all the time, if you hop badly, and I've used the analogy, if you hop like a duck, and you do some sort of intervention to change your pain or change your pathology, do you still hop like a duck? And the answer is yes, you do, because you've done nothing to change the function. You've done nothing to change the capacity of the tendon, the muscle, the kinetic chain, the brain. That doesn't change if you continually direct your treatments at the tendon. It's nonsensical to me that that's going to make a difference. And the answer is we know that if you're dysfunctional, because you have tendon pain, your tendon loads are aberrant, therefore you get more painful, therefore you get into more trouble. So the only way we change tendon pain in the longer term is to change function and make these people tolerant to the loads that we're talking about, energy storage and release, compression loads, all that sort of stuff. You have to change function and you have to change capacity to tolerate loads. Directing your treatments at the tendon might give you short-term relief, and I don't care what adjuncts you use. I do care about really poking the tendon hard. Can be provocative. I don't care what adjuncts you use. I'm not saying don't do anything, but you must do it in conjunction with a proper loading program. That's the answer. So if people need you to touch it or to, massage their muscles or knock yourself out, I haven't got any issues with that. But make sure you get the loading environment right. Make sure you rehab these people appropriately, because that's what's going to give you long-term outcome. Anything else is only ever going to be short-term.
No, I love that. And then I have a friend who's extremely enthusiastic about blood flow restriction training, and it would be remiss if I did not squeeze this in for him there. You were talking about the importance of returning muscle mass when you have these tendon injuries. Do you see any role for BFR training in tendon management?
Yeah, that's an interesting question. I think if you were desperate in terms of time, yes. If you really want to change muscle mass as quickly as you possibly could, yes. The answer is outside of that, no, because it seems that we need the heavy loads to change the mechanical strength of the tendon, the mechanical stiffness of the tendon. So blood flow restriction training means we can get muscle mass without the load. It seems we need the load to actually make the tendon stiffer. The second thing is that heavy slow resistance training is not painful for tendons. So we often use blood flow restriction when loading is painful, such as patellofemoral pain, but it's not painful for tendons. So I don't see that there's a massive place for it in tendons. I think you get results better, as good or better without it.
You know, this kind of leads into the conversation of patient education and then getting them to somewhat change their mindset when it comes to their condition, right? So I don't have the luxury of when people come to see me, I can't pull rank and be like, hey, I'm Joe Cook. This, you know? So a lot of people come in with preconceived biases, and they've been told by their very well-meaning providers that, you know, you need some things to stimulate collagen. You need to try these biologics. Like, how do you break through to them to kind of solve that narrative? Is it just a matter of educating them on the current landscape of, you know, this is kind of what the research says, there's no real evidence for this, but we know this works, or do you have to take a different approach?
Yeah, I think it's really, really hard. In the Desperate and Dateless Clinic, they've tried all that and it hasn't worked. So it's really easy for me to say, well, clearly it's not going to work because of these reasons. It's much, much harder for somebody presenting with very early stage tendon pain and pathology. I don't know that I have an answer, except to say that I think education of the patient is critical. And that's where, as a clinician, you have to have the understanding of what's going on so that you can be clear, because they always ask you a complex question, and if you don't know what you're talking about, you'll get caught out. I think you just got to chip away at it. You know, I don't think you can stop people heading off the PRP injections. I think you can say, fine, if that's what you think you need and your doctor thinks you need, go and have it. But I think we need to be supplementing it with these things. And, you know, when it doesn't work, which it nearly always doesn't, you can actually, you know, you actually get a win there. You can say, okay, well, I told you I didn't think it was going to work. It might give you a couple of weeks of pain relief, usually because you're unloading. Can we try a little bit more of this? The isometrics are fantastic if they're done properly, because you can change people's pain immediately, and they love that. And then you can sort of expand a little bit on the exercise side of things. I spend a lot of time with people in front of a mirror. Can you have a look at your right and left leg, and can you tell me, is one twice the size of the other one? Yeah. Can you hop in front of the mirror? Can you see that you are hopping like an 80-year-old, not a 20-year-old? How can you possibly run when your function is so poor? Can you see that that's going to put really bad loads on your tendon? That's why running hurts you. So a lot of visual feedback can be really good for these patients. So I think you just got to suck it and see a little bit, because some people will respond to different types of education, and I think you've just got to have a go. I think you've got to be careful about being didactic and saying, oh, well, that's not going to work and this is the only way. I think you've got to be a little bit flexible in how you let people try other things, but I think you've got to stick to your message, which is, we can get this better. You give me time and you do some good, fine exercise. I'm sure I can help you. Go off and do whatever you want in the meantime, but this is what I think is going to help.
Okay, so be confident in what we know and don't be a jerk.
Yeah.
I like it. All right. And so when you're doing the things like talking about the visual feedback and showing people their lack of capacity, how do we navigate that while also not trying to feed into some of the things we've seen are important that you alluded to earlier, like in the systematic review done by Mallows, where they talk about the role kinesiophobia may have and some of those factors? People
with tendon pain are kinesiophobia because it hurts. It hurts when they load. Of course they're kinesiophobic. I don't get why this is suddenly a massive thing. You know, if you hit yourself with a hammer on your thumb, you get frightened of hammers and you get frightened of hitting yourself with a hammer. That's exactly what happens. Tendon pain hurts with every step if you've got an Achilles problem. Of course you don't want to be active. Of course you don't want to load that. I get that. I don't think that's novel or new. I think we can measure it. That's fabulous. Whether that feeds into changes centrally, whatever that means, and here I am, another Twitter fight coming up. I don't get all the language around pain that I should understand, and I'm undoubtedly going to put my foot in it here somewhere. But in the lower limb, we don't see much more than kinesiophobia, lower limb tendinopathy. Now, in the upper limb, that's been shown to be a little bit different, but in the lower limb, if you take away their pain with loading, they very quickly recover, and they don't have any long-term strategies. Having said that, I think they have a lot of cortical inhibition. I think their motor excitability says, use your muscle, use your muscle, use your muscle, and because they have pain, their inhibitory sort of drive says, that's really stupid, that's really stupid, that's really stupid. And I think we improve the yes, 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 do this. I think it takes a while for the inhibition to drop down. So I think that's sometimes 12 to 18 months before you really see people let go of that sort of inhibitory drive they have. That's why I think it's so important to keep up strength work in that time after they've returned to sport, before they've really lost their inhibition. I think it's 12 to 18 months for that to happen.
Yeah, and you have to definitely have a lot of buy-in from a patient to be able to stay consistent for that length of time. So that's
yeah, but if they're back and active, so you're not asking them to not do anything, but hopefully they're back and being active. You're just saying, I want you to go to the gym twice a week. It's not an hour. I want you to go in. I want you to knock yourself out on the standing calf raise and the leg press, leg extensions. Take 15 minutes. I want you to do 15 minutes twice a week just to make sure we're keeping that strength up. It's not a big ask. If they genuinely want to get better and stay good, they'll do it.
Yeah, and that's definitely something I try to reinforce with my patients too, is that it's not an out of sight, out of mind kind of deal, right?
Yep. Craig Purdom says, once a tendon, always a tendon. The pathology is always there. You do the wrong thing, the pain will come back.
Mm-hmm. And what you said earlier about the kinesiophobia being directly linked to the pain provocation, and I mean, that kind of falls in line with what Mallow's found in that systematic review, where traits such as depression and anxiety really weren't even correlated with the tendon symptoms, right?
Yep. That's certainly what we see in the lower limb.
So I know a lot of people, they like to impose some of the central sensitization topic on this. Is there any indication that may be a role? Because I know the study I read on that was Plazinga back in 2017, where they did a PPT measure and they didn't really find it. But I know those aren't always the most reliable measure for that. Is there any other data on that topic?
Look, there's bits and pieces of data coming out all the time. I think Ebony Rio is the person you need to talk about this. Her understanding is about, tenfold greater than mine. But I think this concept that it's not nociceptive is just so stupid. I don't understand how it can't be a nociceptive pain, and it can't be persistent nociceptive pain. This idea that it's nociception for 6 to 8 weeks and then all of a sudden it's central is ridiculous. In tendons, we have volleyball players that have patellar tendon pain 5 out of 10 every time they train twice a week, every time they play once or twice a week for 20 years. It hurts when they play. It's gone a day or two afterwards. When they play again, it hurts again. It's still 5 out of 10. It's still in the same spot. You can have persistent nociceptive pain that is not centrally, whatever you want to call it, mediated or changed or anything like that. Just because it's there for a long period of time doesn't mean that it's not still a peripheral nociceptive drive. Okay. No, great. That'll probably ruffle some feathers, but that's good. You are responsible for my Twitter inbox from here on. One thing that you mentioned about the 12 to 18 months that I have found interesting was there have been a few studies done recently that have really expanded the duration of the studies looking at tendinopathy management. So there was one by Massey in 2018 where they actually followed a group for 4 years with functional overload training. And I don't know if you've read this one or not, but no, I haven't actually. What they did was basically they just followed patellar tendon. They used 75% of the 1 rep max, and they had them train. I want to say it was a couple times a week they measured it 12 weeks, and then they had them go off and keep up a program for like 4 years. And they found differences at the end in terms of some of the stress strain curve.
I don't want to dive back into that, but it does seem that there may be slight changes that occur over time. So I'm very curious where that data will go and kind of what we'll find out. But I thought that corroborated what you were saying pretty decently.
Oh, that's good. That's a good start. I think if you change people's pain, you take away people's pain and you restore function, they are going to maintain it with their activity levels. The only time you don't is if you suddenly become less active than normal and then you try and change your activity back up. But the bottom line is if they're pain-free and functional, they will do things to maintain it. So I don't have any particular issues with that. I think that's quite reasonable. It's so different. It comes back to that thing we said is a tendon's not a tendon's not a tendon. The Achilles is so different from the patellar tendon. The patellar tendon is so different from the hamstring tendon. The hamstring is different from different people, different genders, different ages of onset, different responses to treatment. We have to be so careful about conflating all this and simplifying it. For me, as a clinician, you treat the person who's in front of you. You take the knowledge that you have and then you look at that person and you find out what they're missing and you restore that. It's not complex. And too often we don't do that very well. We are driven by recipes, which I hate, of course, but we're driven by something that's worked previously for us and stuff like that, where each person is so individual and needs a tweak or two to a program. You can have something that's similar, but you actually need to treat the person in front of you. I think that's the key thing.
Okay, awesome.
This has been a really interesting discussion. And now, Jill, the last one that we ask is something totally, so it's not clinically related formally.
Yep.
So since the podcast is more focusing on education, we always kind of want to use this last question to kind of gather some data. And we've actually got a lot of it over doing this. So our big cheese, shall you say, is if you could change one aspect of healthcare education, whether that be physiotherapy or other healthcare provider related, which aspect would you change and how would you change it?
Am I allowed 3?
Of course.
I think health literacy is appalling across probably more in musculoskeletal medicine. But if you look at nutrition and you look at smoking and you look at obesity and all that, the literacy of people about their health is appalling. And the problem with the internet is that they can read anything they want. If they want to find out that obesity is good for them, they can find that. So health literacy, I think. And then for me, behaviour change and self-efficacy would be the second things. We can make people literate about their health, but we can't do anything unless they can change their behaviour and they are self-efficacious at it. So, you can talk as a physio till you're blue in the face to somebody. If they're not prepared to do anything about it, then that's, you're done. So one of my wonderful students, we looked at behaviour change techniques and how physiotherapists were physiotherapists comfortable with behaviour change techniques. The answer is no, they're not. They actually don't know how to help people have a positive influence on their health outcomes. And I think for me, that's the big thing. For me, it doesn't matter if you do, ridiculous. I'm ex-Maitland, of course. Grade 1s 30 times on L5 or grade 5, 10 times on L2. That doesn't matter. It's what you tell the patient, how they see that fits into how they change their behaviour, so they can't sit in the couch all night and still, not have back pain. It's how you talk to patients. I think what we do is 90% education psychology and about 10% actually hands-on.
I think that's a really, really good answer because, even just speaking from if we look at just compliance and adherence rates to physiotherapy programs across the country, across the world, actually, frankly, it's really not that good. And, it's interesting that, at least the more, and again, this is more anecdotal for me personally, but the more I've changed, I've only been out for 3 years, but the more I've changed how I really explain why we're doing this and understanding what's going on and trying to fit it into their goals and making it easy and accessible so that it fits within their lifestyle along with their beliefs, that I found, like I found that when you address it from that way, those adherence issues tend to, for the very most part, go out the door.
Yes, absolutely. I would agree. We can't tell people what to do. We have to fit what we want out of them into their lifestyle and their constraints. And you're right. You know, they're fantastic people who talk on this. Jason Silvernail talks on this quite a lot. He's and Susan Mishi did all of the original work on this. I think we have to reflect first our pathoanatomical approach to things, but second, our perspective that what we do changes things. I think it's how we deal with the person, it's how we educate them, it's how we get them to where we want to be that makes a difference.
No, I couldn't agree more. And Jill, this has been an absolutely awesome talk. And I think this has covered tendinopathy from so many different aspects. And I want to thank you and Jason for doing an awesome job of sharing this valuable information. But I recognize too, apart from the Twitter things that maybe might result from this, that there might be some people that also might have some honest questions about maybe some other things regarding tendinopathy or perhaps anything that was discussed. So where can people find you online or on social media should they want to just follow up for a question or just learn a little bit more?
Yeah, I'm a bit of a Luddite. I'm a bit of a tinfoil hat girl. I tend to stay fairly private. I will always respond on Twitter to put direct questions, and I always try to respond to intelligent questions on email. I can't fix your patient on email. I'm sorry. I do get asked that a lot. But if you ask me, if I did this, would this work? I'm really happy to respond. And I'm obviously at La Trobe Uni, so people can find my email there. But I don't have a Facebook presence. I don't have any of the other social media stuff. Twitter's pretty much my only access.
Well, awesome. Well, again, I must say thank you again so much for your time and everything. Keep up the great work you're doing. And thank you so much for coming on.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.